Okay, welcome to our third keynote of the day. Today for this session, I'm joined by Dr. Quinn Pauli, who's GRICON's new science director. What does Quinn do? Sorry, it's not good if I'm too tired at the start of the session. So we've got, I think this is going to be a great session. We have got Quinn, who's going to share insights from the GRI Census with us, and I'm going to talk about our guide for how to treat and cure GRI disorders. So first, before we get into any of that, I'm just going to give a little bit of a quick reminder on a few things that are relevant to both Quinn's talk and to my talk. So, okay, so you can see a bowl here that is oatmeal or porridge. And the reason is because just like in Goldilocks and the Three Bears, IGLURs, which are made up of NMDA receptors made by GRIN, AMPA receptors by GRIA, kainate by GRIC, and delta by GRID. Just like in Goldilocks and the Three Bears, these receptors have to be just right. So these receptors are involved in communication between neurons. They sit on top of the neuron and help the neurons to communicate. And when they're functioning just right, everything is good. So this is, you can imagine that this is like a volume dial. And when the volume is set just perfectly, they're able to communicate well, and everything goes well. But there's other things that can happen. So we can also see that if they're communicating too quietly, it's harder for those neurons to communicate with each other. And that's what we refer to as a loss of function variant. But we can also see problems if they communicate too loudly. And loud and quiet isn't the real term, but this is like an analogy. But it's basically like they're communicating in just such a way that the sound becomes distorted, and they also can't understand each other. And this is what we think of as a gain of function. So just as a reminder, we all, in the case of every one of our genes except for GRIA3, which is a little bit different, we all inherit 2 copies of each gene, one from each parent. And when things are going well, those 2 genes, like let's say these are the GRIN1 genes, they make 2 healthy GLUN1 proteins, and then the proteins come together to form the receptors. And that's good. Everything's in balance. But there are, in addition to just having just general loss of function, there are a couple specific kinds of loss of function variants I want to talk about. So in one case, it's what we call haploinsufficiency, where essentially there's the 2 variants and the one variant, or there's 2 copies of the gene, and one copy has some kind of mistake. And that mistake causes the gene not to make a protein at all. And this is what we call haploinsufficiency, or what we talk about in the How to Cure guide as how to treat and cure GRI disorders as a ghost variant. So haploinsufficiency means that usually there's about half as many copies of the protein as there would be in this top example. What happens in other kinds of loss of function and gain of function is a little bit different. These are, as opposed to ghosts, these are like poison pill variants, where there's still one good copy of a gene and one copy of a gene that has some kind of error in it, and one good copy of the protein gets made, and another copy of the protein, instead of being disappearing like a ghost, it actually gets made, and it harms the receptor when it binds together with 3 other proteins, 3 other GRI proteins that are made from GRIN genes or GRIC genes or GRIA genes. And so if this causes it to be too quiet, it's a loss of function dominant negative or loss of function poison pill. If it causes it to be too noisy, it's a gain of function or a gain of function poison pill. So with that background, I'm going to turn things over to Dr. Pauli to tell us about the GRI Census.
Thanks, Keith. So GRICON launched the GRI Census back in August 2024. This is a IRB-approved study that was basically designed to collect data from parents and caregivers of individuals with a GRI disorder, which is really important for understanding breed disorders and patient priorities, even within different groups, to advance our search for treatments and cures. We are planning on publishing some of this data, but I just wanted to show you kind of some initial high-level insights today. So total responses as of February 2026 is 546, which is amazing. And some of the analysis that I'm showing today will include kind of a broader population, but more of the detailed analyses were performed on 399 of those responses. And that's because those particular variants were classified as pathogenic or likely pathogenic using kind of a standardized set of criteria. And basically what this means is that experts are confident that the variant is actually causing the symptoms. In contrast, variants of uncertain significance or VUS, we just don't have enough information basically to know if it's the cause of the symptoms yet. So there's about 88 responses in that case. And as we get more information, we will update accordingly. Within those 546 responses, we also identified 365 unique variants across the genes that are listed here. So the GRIN genes, GRIN1, GRIN2A, GRIN2B, GRIN2D, GRIA1, GRIA2, GRIA3, GRIA4, and then GRIC2. And so we were actually able to look at the variants that individuals reported and link them with information that's already out there about their functional effects. So this is what Keith was referring to earlier. So this is loss of function, gain of function. And that information is available for GRIN genes through the GRIN portal. And the Center for Functional Evaluation of Rare Variants did this classification. And so when that was available, we were able to link that information. And for the other genes, we searched through the literature to see if any characterization had been done on those variants. The census remains open for participation, but I'll be going through kind of the data that we've received so far. So this is just an overview of the participants. So you can see each gene and the number of participants in that graph on the left. You'll also notice that there's about a 50-50 split between male and female participants. And you'll also notice that most participants with the GRI disorder were less than 10 years old at the time of census completion, but we do still have older participants as well in that, in the teenage years and adult years as well. So here I'm just showing kind of where in the world the participants in the census are located. As you can see, we've had really great participation globally. This map shows where there are at least 3 participants in the census. And most of the participants are located in the US and in Europe, about 80% in total. So now I'm going to talk more specifically about symptoms, and this is where we kind of focus specifically on the pathogenic and likely pathogenic variants. So the end values that you'll see in these slides going forward represent the number of participants in total. So you have an idea of how many people contributed to the data that we're showing. So this graph, along the left-hand side, we can see all of the different symptom domains that we specifically asked about. And then along the top, we're seeing the percent of participants that reported experiencing these symptoms. And they're color-coded accordingly. So we asked whether the individual had experienced that particular symptom recently in the past 30 days. So we consider that more of a current symptom. Whether the individual had experienced that symptom in the past and may not be experiencing it anymore, that's in orange. In purple, this is individuals who reported not experiencing that particular symptom domain, or the participant was unsure or didn't know, and that's in gray. And so you can again see the number of participants that correlate to these percentages here. And really what I want to point out on this slide is that there are 6 top symptoms where about 90% of patients have or have had that particular symptom. So that includes developmental delay, speech delay, muscular issues, and gross and fine motor delays, as well as intellectual disability. So those top 6 show up again and again for our population. And then there's also a range of other symptoms that people report to varying degrees. For example, sleep issues that can include trouble falling asleep, interrupted sleep, coordination issues like ataxia, clumsiness, difficulties with balance, as well as feeding and GI issues like constipation, reflux, feeding difficulties, issues with diet. So I just want to point out there is quite a range of symptoms, but those top 6 are really common for the entire GRI community. So this is just summarizing for each gene along the top, which of those symptoms, the same symptom domains that I showed in the last slide, are in kind of the top 6 symptoms. And what I mean by that is that we looked at the percentage of individuals who are either currently experiencing those symptoms or had experienced those symptoms in the past. And that's how we kind of got this list of top 6. And so we can look, and again, this is including the pathogenic and likely pathogenic variants, but I will say we saw very similar results when the VUSs were included as well. Note for some of these genes too that there are smaller sample sizes. So you can see GRIA1, for example, we had 7 participants. So when you see sample sizes like that, just basically low number of participants, just be aware that there could be, the data might not be as reliable. It could change when we have more participants. So just keep that in mind. But again, what we really see in this slide is that those top 6 symptoms show up again and again across every gene. But there are a few symptoms that seem to be more gene dependent. So for example, epilepsy and seizures showed up in the top 6 symptoms reported for GRIN2A and GRIN2D specifically. Coordination issues specifically showed up for GRIN2A in the top 6. And mood and behavior challenges showed up for GRIA1. And keep in mind that there's lots of participants across these genes reporting a range of symptoms. These are just the top 6. And we can also break this down in other ways. So if you go to the next slide. So we can also look at the functional effect of the variant. So like I mentioned, we were able to obtain some data from the GRIN portal for GRIN variants, and we also searched the literature for the other variants to see whether that functional characterization in a lab had been performed to tell if the variant is gain of function or loss of function. And this is actually the first time that we're able to share this data on functional effect. Again, you can see the number of participants. This is all genes grouped together in this chart that I'm showing you, just for the sake of time. And so another thing I want to point out here is that for haploinsufficiency, that category here, this is something we actually predicted based on where the variant occurred and what type of variant it was. So there are certain variants that are suspected to shorten the protein. And if that variant occurs before a certain point in the gene and in the protein, then the cell machinery generally doesn't, finish making the protein and deliver it to the right spot. And so generally we consider that kind of a ghost protein or haploinsufficiency. So that's a specific type of loss of function. And then in contrast, we have loss of function dominant negative, which means that that's a missense variant. So just one single change in a letter in the DNA code that's causing a loss of function effect. So we can kind of get loss of function in these 2 different ways. And note that, for the haploinsufficiency category, that's a prediction that we're making. It hasn't necessarily been tested in a lab. And then there's also a section of variants that haven't been characterized or indeterminate. So really what the takeaway here is that when we're looking at those top symptoms, again, showing the exact same symptoms on the left-hand side, you can see a large majority of participants, regardless of the type of variant, experience those symptoms. So this is something that I want to emphasize, is that you can't tell whether the individual has a gain of function or loss of function variant simply based on the symptoms. There's a lot, despite the receptors working in different ways with these different variants, there's a lot of overlap between the symptoms that are observed. And so what these numbers are is that it's the percentage of individuals who have experienced or are currently experiencing the symptom. And what I really want to emphasize is that one of the symptoms that could change or occur more frequently in certain parts of the population is epilepsy and seizures. So you'll notice that under the gain of function heading, there's about 75% of individuals with gain of function variants reporting epilepsy, either currently or in the past, compared to either of the loss of function types that are only about 37 to 38% of individuals. So that means that epilepsy and seizures seem to be more common in gain of function variants. And there are some other symptoms where that, similar pattern might be seen, or there may be some differences in functional effect of the variant as well. But the epilepsy and seizures is kind of the most striking example there. But I will note that epilepsy and seizures is seen in both types. So just getting more into epilepsy and seizures specifically. So this is really one of those gene-dependent symptoms as well. So what you're seeing on the graph on the left is along the bottom, the genes, again, with the number of participants, so be aware of that. And we're seeing the percentage of participants who, again, reported recently, in the past, or has not experienced, according to the colors. And so you'll see that there's some change along those genes there, indicating that some genes like GRIN2A and GRIN2D, there's a higher percentage of participants with epilepsy and seizures. And when we look at all the genes together, we asked individuals what types of seizures they were experiencing. And the most common was absence seizures, followed by tonic seizures, focal epilepsy, and then ESES. Another symptom that could, kind of change based on what group of individuals we're looking at is muscular issues. So the 4 graphs here are showing all of the GRIN genes combined with gain of function variants or loss of function variants, and that includes dominant negative or haploinsufficiency. So that poison pill or ghost combined together. And then on the right-hand side, same breakdown for GRIA. And so here you can see that hypotonia or low muscle tone is really, really common across all of the groups. So, 70 to 80% of participants reporting low muscle tone. However, if we look at hypertonia or high muscle tone or spasticity, there could be some differences between these groups here. So we're actually seeing that about 40% of participants with gain of function variants in the GRIN genes reported this high muscle tone or spasticity, compared to only about 15% of the loss of function variants. So there could be, again, these differences in this particular symptom, and that seems to carry over for the GRIA genes as well. Another symptom that I just wanted to talk a little bit more about is mood and behavior challenges. We don't see as much of a difference between the different genes, but it is a symptom that's reported in about 50% of individuals. And as you can see, when we look at the types of mood and behavior issues across all of the genes, when we break that down, you can see some examples here. So for example, increased startle response, self-harm. And in that other category that comes out on top, that includes things like anxiety, tantrums, bipolar disorder, ADHD, mood swings, aggression, irritability, and anger. Those were some commonly reported ones. So now I'm switching gears a little bit here. Another thing that we asked about, rather than just asking which symptoms has the individual experienced, we're also interested in kind of getting a sense of how severe those symptoms are. And one way we ask that is by asking, how does the individual compare to peers of the same age? Are they severely behind in blue, moderately in orange, a little behind in purple, or about the same or better than peers of the same age? And so kind of what we take this as is a higher percent of individuals reported to be severely behind peers of the same age could indicate a more severe form of the disorder. And so what I'll point out here is that GRIN1 appears to be the most severe in this particular domain, which is intellectual and cognitive abilities. Relative to peers, they're reported to be severely behind in about 95% of participants. That's followed by GRIN2D, GRIN2B, and then some of the GRIAs. Overall, I also want to point out that most participants, regardless of gene, reported that the individual was either severely or moderately behind peers of the same age in intellectual and cognitive abilities. So this is very common for all participants as well. And then we can also break this down by functional effects. So again, that gain of function, loss of function, dominant, negative. So that's from that missense variant, or haploinsufficiency, where the protein may not be made. And really, what is important here is that, again, a lot of people are reporting that the individual is severely or moderately behind peers, but with predicted haploinsufficiency, there's a lower percentage of participants that are reported to be severely behind peers of the same age. So that indicates that haploinsufficiency may generally be milder than some of the other forms or functional effects of the variants, but that may be different for some of the genes. Here we're seeing kind of the same measures. So again, looking at the individual relative to peers, overall, we're seeing similar trends here in speech abilities, with GRIN1 showing the highest percentage of individuals severely behind peers of the same age, followed by GRIA2, GRIA3, and then some of the GRIN genes. Again, haploinsufficiency may be on the less severe side. And similar for gross and fine motor skills as well. We also looked at quality of life and skill regression and progression. So we asked people, overall, how would you rate the individual's quality of life? And across all of the participants with pathogenic and likely pathogenic variants, you can see in this chart, it's about a 50-50 split between excellent and good quality of life versus fair or poor quality of life. And when we include those individuals with variants of uncertain significance, those trends hold up. The data looks very similar. And then also asking generally, have the skills improved or progressed or regressed in the past year? As you can see, most people reported that they progressed or stayed about the same, with a smaller percentage reporting regression. And then this just shows the breakdown by gene and by function. So there could be some differences in quality of life by gene here. For the functional effect of the variant, again, haploinsufficiency has a higher percentage of participants reporting good quality of life compared to gain of function or loss of function, dominant, negative. So again, this could be an indicator that haploinsufficiency is kind of less severe. And similar trends here for skill progression and regression. Next, we also asked about certain milestones. So when the individual was completing the survey, could the person with the GRI disorder complete these milestones? Can they sit up independently? Can they support their own weight? And so on, as you can see listed across the top. And the percentages here are the number of participants. And we also split this up by age category. So at the time of survey completion, can this individual, perform this task or skill? And so, what I want to point out here is that generally, for some of these milestones, you can see an increase in the percentage of individuals who can do these things as age increases. So, we're not tracking individuals over time, but generally this trend suggests that some of the missed milestones in those early 0 to 4 years could just be missed. And, they may be coming later on. We're not really sure why some of the percentages are lower in the 20-plus-year-olds. We just don't have enough information, but it doesn't necessarily mean that people start like losing skills after that age or anything. We also asked about therapies. So which particular type of therapies have people tried and have found either helpful, not helpful, or they're not sure? And I think really what the takeaway of this slide is that overall, at least 50% of participants found physical therapy, occupational therapy, and speech therapy to be helpful, with a much lower percentage explicitly saying that it was not helpful. And even for some of for the other therapies like osteopathy and vision therapy, generally people found those helpful or have not tried them yet. And then we also asked about medications. So we explicitly asked participants to list medications that they have tried and found most helpful um, for their symptoms. Now, I want to note we can't, of course, we can't provide any medical advice. So if you have any questions, any takeaways from this slide, please discuss that with your doctor. But what I do want to point out is that when we're looking at the top 6 drugs that individuals listed and found helpful, they seem to be really related to the receptor that the particular gene affects. So what I mean by that is that when we look across the top, I've included GRIN genes overall on the left, so all the GRIN genes, GRIA genes on the right, and then the 4 charts below is GRIN broken down by different functional effects. We don't quite have enough participants to break GRIA down in the same way, but what you can see is that for the GRIA genes in that top right-hand graph, that perampanel was the most commonly reported drug to be helpful. About 18% of participants reported that to be helpful. And perampanel is one of those drugs that targets the AMPA receptor. It's a antagonist specifically. So that makes sense. And when we look at the GRIN genes, particularly those loss of function, so the bottom left-hand corner and on the right-hand side, that haploinsufficiency, in both of those groups, L-serine came out on top. And L-serine is an agonist of the NMDA receptor. So again, this makes sense. And specifically, we see that for the loss of function variants. So this is also, why it's important to understand when we're able to the functional effect of a variant. And lastly, what I'm showing here is the top priorities for that individuals would rate for treatments and cures. So this particular chart includes pathogenic, likely pathogenic, and also variants of uncertain significance. And we asked participants to list their top 3 priorities. And so this relative importance index takes into account both the number of individuals who rated that particular symptom as a priority and also how highly they rated it. So 100% on the scale at the top, it only goes up to 40 here just because of the responses we received, but 100% would be every single participant rated that particular symptom as their top priority. And so what you can see here is that seizures and epilepsy comes out on top. This is, the top priority for the entire community when we look at all of the genes and all of the functional effects of the variants. And later on in the slides, you'll see that kind of broken down by gene as well, which looks a bit different. And I'll also mention for individuals that have not experienced seizures and epilepsy, the following, the ones underneath seizures and epilepsy came out on top. So things like intellectual disability and delay, speech delay and disability, mood and behavior challenges, and developmental delay. And with that, I'd just like to thank everyone who has participated in our census, to our partners, and also to the CureGRIN team. And I'll hand it back over to Keith to talk about the guides.
Okay, thank you so much, Quinn. So 7 years ago this spring was when we first founded CureGRIN. And at the same time, my wife and I made a trip and we traveled to Boston and met with a number of industry drug makers, pharma companies, biotechs. And we kind of asked them what it would take for us, what it would take us for them to be interested in developing treatments and cures for GRIA disorders. And they gave us an initial list of things like having preclinical models, so animals and cell lines, having a patient registry where we can get good data on our patients and kind of look at how the disease progresses over time, and trying to find biomarkers. So those were some of the things that we realized were early priorities for CureGRIN. But as we've had more meetings with industry, the questions have become, that they're asking us have become even more complex. And so what we wanted to do is to try to put together a guide for industry that could help them to better understand all of the GRIN, GRIA, GRIC, and GRID disorders, as well as lay out all of the different ways that we think you can build what we're calling intervention. So basically different kinds of treatments or curative approaches to help our patients. And so this process of getting to this how to treat and cure GRI disorders guide started about a year and a half ago, almost 2 years ago, in Toronto, where we had we brought a number of researchers together and met for 2 days. So you can see a lot of the people who are on our panels here today. So a lot of the experts in the world of GRI disorders came together, and we started to try to identify all the special significant points about all of the different disorders that we could leverage in terms of treatments and cures. And we talked about traditional drugs like small molecules. We talked about genetic medicines. We talked about some of the things that were cutting edge now and cutting edge then and are starting to become more researched now. So it was a great beginning. And then since then, we've been working at putting together, this is, warning, this is an AI generated, so this is not what the book will look like, but an actual guide that we're going to share with industry that outlines how to treat and cure GRI disorders. This is not a short guide. It's going to be about 200 pages long, and it includes over 80 different ways that we can find treatments and cures for our patients. And so what we wanted to do today is to take you through kind of some of the highlights of that. And one of the things that we can do in the guide, and by the way, I should note that we're also building a shorter and less scientific version for families of this guide that we'll be releasing soon. So in the family guide, it's going to be a little bit different in terms of the way we lay this out, but we believe that there's actually 6 questions to ask about each variant that will help us identify which is the correct of 7 strategies. And so today I'm going to talk about those questions, talk about the strategies, and then briefly talk about how those apply to the specific genes. But we're also going to share pieces of this presentation over the next couple of weeks so you can look in more detail about what all of this means for your specific child and your specific gene. So the first 2 of these questions to determine the right treatment for the right variant, we've already talked about. So one is the variant gain or function or loss of function? So we've talked about that. The second question is if it's gain or loss, if it's loss, is it dominant negative like a poison pill, or is it haploinsufficiency as a ghost? So we've talked about that. It's also important to note that in addition to just being haploinsufficient, there are 2 different criteria or 2 different categories of haploinsufficiency that could affect the range of treatments that are available for patients. So this kind of shows different kinds of variants that can happen in patients. So if you look at these letters on the top, A, T, G, C, that's a segment of a theoretical gene, and that gets spelled in these 4 different letters. You can see in a missense mutation, which is actually what most of our patients have, where there should be a G, it got changed to an A. In this example of a nonsense variant, where it should spell CAA, it's been changed to TAA, and that 3-letter code TAA tells basically tells the cell to stop making the protein. And so it doesn't finish reading all of the DNA, it just stops right there and results in, if it's early enough, if it's not right at the end of the variant, it usually results in a nonsense, or it is a nonsense variant, it usually results in haploinsufficiency or a ghost variant. But this haploinsufficiency or ghost can also happen in another way, usually a frame shift variant, which is often where there's a letter added in. It will cause every letter after that to be off by 1. And usually that will make maybe 1 or 2 proteins or 1 or 2 amino acids that are not the right ones, and then it'll come across a premature stop codon, and that also adds to a nonsense variant. And the reason this is important is because there's something called a read-through therapy that I'll talk about that will work for nonsense variants, these pure nonsense variants, but not ones where a frame shift leads to a nonsense variant. The next question, I'm just going to talk about this really quickly, but does the in addition to, when we talk about usually the way that we see on the right here, usually with a receptor, it's either too loud or too quiet. We've talked about that. But sometimes the actual receptors on the surface are being formed correctly, but the problem is either that they're not anchored to the receptor, they're not anchored properly to the synapse, or that they are the receptors are not in the right place in the synapse, so that when they're trying to receive what the receptors receive, it just kind of bounces off and doesn't get in. So often the therapies are to increase or decrease what's going on, but for those ones we need special kinds of interventions. The next concept is around the developmental expression profile of the gene or protein, and this is something where we honestly don't know all that much about yet, and it's something that we're still in the process of discovering. In Amy Ramsey's presentation earlier today, she talked about how her lab a few years ago did a piece of work where they created a mouse that grew up as if it had GRIN1 variant, and then either when the mouse was an adolescent or where it was an adult, they turned off the disorder. So suddenly it was like the mouse's genotype was cured. And what they saw is that the phenotype partially followed. So even in adult mice, if you fixed the gene problem, the mouse became smarter and more social and stronger. So there were good improvements that could happen even with a later intervention. But we know that GRIN1 is a gene that expresses evenly through life, where there are other genes that express more in the very early stages of life. So an example is GRIN2D, where that expresses very early. And there's one case study that I'll mention where a paper by Dr. Lemke and his team talked about two siblings that had the same GRIN2D variant, and they were treated with memantine. And one was a 2-year-old child, and for the 2-year-old child who got this memantine treatment, they saw significant improvements in seizures and developmental gains. Unfortunately, in the older patient who was 6.5 years of age, there was no improvement in seizures. In fact, they actually got worse over time, and only mild improvements in developmental delay. So this is just one case. It's not necessarily because of this reduction in the expression of the gene that made the difference. It's possible that it was. But the good news about all of this is that we also know that there are now medicines that can reopen the window of brain plasticity. So it's possible that giving some of these medicines along with other kinds of treatments or cures could mean that even for these genes where potentially earlier intervention would be better, that it might be possible to give 2 different medicines and improve the chances of those medicines working at a later age. And of course, it's important to note that this is Stan Crook. He's the founder and chairman of Lorem Foundation. Before this, he started Ionis, and he's sort of famous for developing the industry around antisense oligonucleotide treatments. And he said, we've learned unequivocally and clearly that all the things we were taught about developmental delays being permanent is simply not true anymore. So certainly we have hope that even if this kind of sunsetting of genes where they express themselves less as people get older does have an effect, that there'll be other things that can be done at the same time to mitigate that. So the next question is whether the gene has a profile of haplotolerance. So there are, we talked before about haploinsufficient genes where having one missing copy of a protein results in a ghost profile, but not all genes have this. So even within the GRIN genes, there's a spectrum where some of the genes are very haploinsufficient, and an example of that is GRIN2B, where we see people who have a missing copy of a protein have a significant phenotype, significant symptoms, where there are, on the other side, some genes where they're much closer to being haplotolerant. So GRIN1, GRIA2, GRIN1, GRIA4. There's several of these that we don't see patients with them in the GRI census, and there's scores that kind of suggest that these having both healthy copies of this are not quite as important. So these are more haplotolerant, and this also has an impact on what you can use to treat. So then, based on those questions, we've got in the guide 7 strategies and 80 interventions. And I know that we don't have a lot of time left, but I'm going to go through these interventions fairly quickly. So you can just see a slide there that has an example of some of the interventions that are outlined in the guide. But the 7 strategies, the first one is boost, or the first 2 are boost and reduce. And a lot of these have to do with small molecules. So small molecules are basically what we traditionally think of as pills or medicine, where they are something that kind of float. After you take a medicine, it'll kind of float around and look for it's almost like a puzzle piece, and it looks for the right place to plug into. So an example of this is aspirin, that is a small molecule that binds to the COX-1 and COX-2 proteins. And similarly, radiprudil is something that binds to the GLUN2B protein, which is the protein that's made by GRIN2B. So the theory of small molecules generally is that if someone has a loss of function disorder, you want to give something that can kind of tune this dial, or sorry, if there's a gain of function, a loss of function, you want something that can tune this dial up. So these are known as either agonists or positive allosteric modulators, or if someone has a gain of function, you want small molecules that can turn the dial down, and these are known as antagonists or negative allosteric modulators. So these can generally be applied widely, and so one of the benefits of these small molecules that we see, for example, in radiprudil, is that that Quinn Therapeutics believes that it can help patients not just with GRIN2B where it binds, but across the GRIN disorder and gain of function variants in GRIN1, GRIN2A, and GRIN2D as well. The next one is knockdown as a strategy. So this is best for gain of function or loss of function in haplotolerant genes. And you can see that it can be built in different ways. So in the example at the top, we talked about how you get one copy of a gene from your mother and one from your father. So you could see here if one is if half of the genes are broken and half of them are good, then maybe you target, if you have a non-selective knockdown drug like an ASO or antisense oligonucleotide, you knock everything down and you have a smaller number of these proteins overall. But an even more powerful technique is that you can make it allele selective, so that all it does is knock down these broken genes so that they don't make receptors. And then what you'd effectively end up with is a haploinsufficient version of the gene. And so for genes that are haplotolerant, knockdown can be a very effective strategy. And there are versions of this that target both the DNA and the RNA, like the examples that we heard of if you were in the session on genetic medicine. The 4th strategy is augment. This can work both for haploinsufficiency or for poison pill. So in a ghost variant, it can be pretty clean. The patient starts with half as many of the protein, and you can use this augment strategy to basically replace the missing ones. But with a poison pill, it's a little different, because you can have, the patient might have an equal number of the good and bad genes making the good and bad proteins. And then basically what you can do is augment to water down the number of the bad proteins that get made. The 5th strategy is where it all comes together. So this is known as knockdown and augment, or knockdown and replace. And here, this is something where you can both increase the good and knock down the bad. And this is something that could be great for any variant. The read through I talked about earlier as something that can help with these pure nonsense mutations. So there's two different versions of this kind of technology. One is a gene therapy that can actually fix it to make it the correct protein. There are also small molecules that tell it to kind of fake it and pretend that it's got the right protein. So both of these are good options for these pure nonsense variants. And then the final example here that I'll talk about is the edit strategy. There's two examples of that here. And again, this can work for almost any variant. So prime editing, you might go again back to if the letter should be a C, but it's an A, you can inject the right letter and fix that single misspelling to fix the phenotype, where there's something called twin prime editing, and this is kind of at the leading edge. But this is where, let's say that there's 5% of a gene that has 20% of the variants. You might build a bigger set that could go in and fix all of these variants with one single medicine, or even more advanced is the potential that it could replace the whole variant. So then we get into these slides that I'm not going to go over today, but these are kind of come out of this, and this is what we're going to talk about, or this is what we're going to share and make available over the next couple of weeks, so you can see how everything that I talked about applies to each individual gene.